The image in the New England Journal is shown here. 52-year-old man comes to an outpatient clinic, and he has a bleeding mass on his right toe. And if we look at this story, this has been going on for several weeks. Actually, it's been going on for several months, so this is not an acute problem. Somebody also stepped on his toe. Looks like that might be possible. I think what's disturbing here is this is not the right joint for gout, so we can forget that. He could have a subungual hematoma, but that's not all that relevant. Neurofibromas do occur on toenails, but that's not terribly common. A subungual exostosis should be lateral and perhaps involve the bone. And we're left with the worst in terms of prognosis, diagnosis, lentiginous melanoma. And if we look at this toe, there's dark discoloration here in the nail bed and also here in the nail on the medial aspect of the toe. And my advice is always, if you have no idea, always pick the diagnosis with the worst prognosis. So we'll pick acral lentiginous melanoma, and that's the correct answer. If we look at these other items here, gout involves this joint. Although the toe is also a little bit involved in this patient, but gout involves this joint. This is a subungual hematoma. Presumably somebody stepped on this person's toe. Neurofibromas, if they're isolated, might look like this. If they're all over the place, then we would suspect the patient might have neurofibromatosis. Not really that common on toenails. Here's an exostosis, so that looks like entirely different. So that's the image for the week. The first paper concerns artificial pancreas. This would be a sensor and an effector, and the sensor drives the effector so that the patient basically has to do nothing. Now, we had such a device when I worked in Indianapolis in 1980, an artificial pancreas. The problem was that the device was about the size of the patient, but modern electronics has changed all that. So we see a sensor and an effector that's involved in a closed loop kind of system. And in this particular article, we compare a closed loop system to a sensory-augmented system. Now, both of these people have a sensor that monitors blood sugar continuously. And the patient with the sensor-augmented system also has an insulin pump, but the patient has to drive it. And in the closed loop system, the machine drives it. Now, these are not yet perfect because the ingested carbohydrate amount has to be typed into the closed loop system, but it's pretty much a closed loop system. And in this particular study, sensor-augmented system was compared to closed loop system, so open loop against closed loop. And the primary endpoint here is the amount of time in which the target blood sugar is between 70 to 180 milligrams per deciliter. And if we look at the patients here, these are all type 1 diabetics. And most type 1 diabetics are young people, so that there are a lot of people that are under 18 years of age, although this is not a pediatric study. Now, these patients are really pretty good patients because they're already being treated with insulin pumps, which in the United States is not necessarily all that routine. And if we look at their social background, as an exception it's worth looking at here, 2/3 of these patients are from families that make more than $100,000 a year. And their level of education is also much better than the average patient that we would see with type 1 diabetes mellitus. And at screening, their HbA1c levels are really pretty respectable. So these patients are basically professors' cases with type 1 diabetes. And if we look at the primary and secondary outcomes here, we see that the closed loop system beats the open loop system. Not by much, but it does beat the open loop system. And if we look at the blood sugar values, closed loop system has better blood sugar values. The glycated hemoglobin level drops by about 0.37%. That's not very much, but it's statistically significant. And if we look at episodes of hypoglycemia, those were not the problem. So here's the percent of time with glucose between 70 to 180 milligrams per deciliter. And the closed loop system beats the open loop system by about 12%. And if we look at the time with glucose here expressed in another fashion, again, closed loop beats open loop because closed loop important morning hours is above 80% and open loop is not. And if we look at glycated hemoglobin levels over this 26-week period of this study, they're also a little bit lower in the closed loop patients compared to the open loop patient. And if we look at hypoglycemia, if we look at the time with glucose concentrations that are less than 70 milligrams per deciliter, closed loop patients are a little bit better than the control patients. Now, there was one episode of diabetic ketoacidosis, and that was a patient with a closed loop pump, but the investigators attributed that to pump failure rather than some specific medical reason. So if we look at this graphically, here's the closed loop people, 71% of the time they made goal, and the open loop patients that also did very well, they made goal about almost 60% of the time. So closed loop beats open loop, and I think that that's the wave of the future, and in the coming years, hopefully, everybody with type 1 diabetes will be on a closed loop system. The next topic at the New England Journal is lung fibrosis, idiopathic pulmonary fibrosis, which can be secondary, but also can be primary. And these individuals do not have an obstructive form of lung disease, although there may be a component of obstruction. Their primary problem is fibrosis that results in a reduction in forced vital capacity and eventually pulmonary failure. We don't have very good treatments for this condition, although, as we're going to see, there may be a tyrosine kinase inhibitor that helps some of these patients. Now, pulmonary fibrosis can also be secondary to a whole host of connective tissue diseases and also acquired toxic problems, cocaine abuse, and side effects from certain medications, and asbestosis, silicosis, talc, Xylophiler's disease, and various conditions that can really cause an identical clinical syndrome. Now, what's helped the diagnostics here substantially is detailed CT analyses, and I've shown some examples of CTs that are much more impressive than we would see from a conventional chest X-ray. Now, in this study, patients with pulmonary fibrosis of various backgrounds were recruited, and they were randomized to treatment with nintedanib. Nintedanib is a tyrosine kinase inhibitor. It inhibits VEGF. It inhibits fibroblast growth factor receptor. It inhibits, and this may be the most important target, PDGF receptor. And in earlier studies, we've seen some benefit in pulmonary fibrosis patients treated with this compound. In this particular study, the spectrum of pulmonary fibrosis patients that were recruited for the study was greater than had erstwhile been the case. These are mostly older adults. Smoking seems to be a risk factor. Disease progression forced vital capacity is reduced in these patients. Eventually, carbon monoxide diffusion capacity is reduced, and there are questionnaires concerning quality of life. The King's Brief Interstitial Lung Disease Questionnaire assesses their quality of life. And the endpoints looks like nintedanib preserved forced vital capacity to a modest extent. And we can look at these results here. The overall population and patients that had a particular fibrotic pattern, the placebo group deteriorated at a greater rate over 36 weeks. This length of the study was a year. Than the nintedanib group that were able to preserve their forced vital capacity over this period of time. And that result was statistically significant. Death was considered to be a fatal adverse event, and the death rate was higher in the placebo group than in the nintedanib group, although that result was not statistically significant. The most common adverse event of this tyrosine kinase inhibitor was actually diarrhea. Nausea, vomiting, abdominal pain, decreased appetite, and weight decrease were more frequent in the nintedanib group than in the placebo group. Unfortunately, despite the favorable effect on forced vital capacity, the patients didn't feel any better. So their quality of life, despite this positive effect of the drug, was not improved. Maybe we'll need a longer follow-up. The next topic is acute myelogenous leukemia, which is an acute leukemia that is seen primarily in adults and particularly older adults. The disease has a poor prognosis, and it's associated with a variety of genetic alterations, and it's more common in patients with Down syndrome or with Fanconi's anemia. I wasn't really aware of this, but 30% of the patients with acute myelogenous leukemia have activating mutations or some sort of translocation that involves FLT3. FMS-like tyrosine kinase 3 mutations are common in patients with acute myelocytic leukemia. The FMS-like tyrosine kinases were first discovered in cats with sarcomas, and FEMS stands for feline muscle sarcoma, FEMS. So FEMS is a family of tyrosine kinases. We're familiar with FLT1 because of its association with preeclampsia. Here we're talking about FLT3. Gilteritinib is a blocker of the FEMS-like, of the activated FEMS-like tyrosine kinase 3. And in this particular study, patients with acute myelogenous leukemia that had various FLT3 mutations were randomized to this tyrosine kinase inhibitor compared to salvage chemotherapy alone. And I've already summarized the results here. The mean overall survival in the tyrosine kinase inhibitor group was 9.3 months, and in the conventional treatment, it was 5.6 months. Now, I guess I'd rather live 9.3 months than 5.6 months, but this result cannot be considered a cure, obviously. Here are the patients, and they all have some sort of FLT3 mutations that are outlined here, and the various treatments that they've had prior to be randomized in this trial. Anthracyclines are commonly given for this condition, are shown in this table. These are, on the average, older adult patients, and half the patients were female. And here is the overall survival. And if we look at this, okay, in 9 months compared to 6 months, not dramatic, but the gilteritinib group did better than the salvage chemotherapy alone group and so perhaps this treatment has something to offer these patients. Now, the anti-leukemic responses in a few patients were quite impressive. In other patients, not so impressive. And if we look at the adverse events, primarily what struck me was alterations in liver function. Alanine aminotransferase is more commonly increased in the verum group, and alkaline phosphatase increases were also observed. So it's possible, first of all, the important messages here is that FLT-like tyrosine kinase 3 is commonly mutated in patients with acute myelogenous leukemia. There is now an inhibitor of FLT-like tyrosine kinase 3 that offers these patients improved survival. Hepatotoxic effects bear attention in future studies. Then the fourth paper in the New England Journal I thought was rather impressive. It concerns burnout of physicians. And burnout is sort of a catch-all term for individuals that have a tough time at work. And they develop basically depersonalization. They develop emotional weakness, and they're no longer effective in what they're trying to do. Now, burnout amongst physicians is fairly common, and this topic was studied in physicians that are in training to become surgeons. Now, this is a cross-sectional national survey. All of the residents in surgery in the United States were subjected to this survey, conducted in 2018. And since the trainees in the United States, the surgical trainees, internal medicine trainees also, are assessed with a training examination, these physicians were a captive audience to be enrolled in this study. And the first thing that impressed me is that this kind of study would never be done in Germany. The training programs in the United States are coupled to institutions. In Germany, they're coupled to individuals, is the first point. And the second point is that there's no training examination, to my knowledge, in Germany, either in surgical residencies or in internal medicine residencies. So all these captive individuals were subjected to this study. And what we see here is even in surgical training programs, here 40% of the trainees are now women that are going to become surgeons compared to 60% men. We know that amongst the medical students now, almost 2/3 of the medical students are female. That's the case in the United States and also the case in Germany. Clinical postgraduate years were scattered. It's a 6-year training program in the United States, or a 5-year training program in the United States. Some of the people were married, some of them weren't. And academic programs, community hospital programs, military programs, and other programs are all represented in this survey. Now, to go over the details in these tables probably sort of is outside of our realm, but you can look at these things. What impressed me is that the harassment and the pressure on these trainees was not only from attending surgeons, that only amounted to 30%. 15% was from other people in the training programs. That means their immediate associates. And the rest was from the patients themselves or the patients' relatives, made up a good portion of this abuse that these individuals experienced. Also, the training program in surgery and the internal medicine in the United States now states that the trainees are not allowed to work more than 80 hours a week. In Germany, it's 49. So these people weren't supposed to work more than 80 hours a week, but it was relatively common that these individuals had to work more than 80 hours a week. Now, we need some flexibility in these training programs, and I'm sure this wasn't too common because the penalties here involve the training programs instead of individual chiefs of service. And if a hospital loses its training program, this is basically a disaster, so they don't want to do that. There are more details here in terms of emotional exhaustion, depersonalization, and overall burnout. So I think that this is a courageous study, and it warrants consideration, not just in the United States, but in all countries, because suicidality and mistreatment are things that we'd like to avoid. Now, the review in the New England Journal was on schizophrenia, which is a psychotic condition where individuals basically lose contact with reality. There are various forms discussed in this review. Late teens and early 20s are usually the ages of onset, although there's a spectrum of age. According to twin studies, the heritability of schizophrenia is about 80%, but twin studies that involve monozygotic and dizygotic twins generally overestimate the heritable component. So the role of dopamine receptors and dopamine has been inferred from studies involving various medications. The DSM-5 criteria for schizophrenia are listed here, and you should inspect these so that you're familiar with them. The medication spectrum that's used to treat schizophrenia, haloperidol is actually the only drug that I've had personal experience with. I was relieved to see that it's still on the list for treatment of schizophrenia. These other compounds, I have no clinical experience, but you can look at the details that are outlined here. Management of poor and partial response is an important issue. What to do with medications when individuals get better? Should the medications be continued? And is this important for relapse prevention? And because lay people commonly ask, I was relieved to see that this discussant says that cannabis has no role in the treatment of schizophrenia. The side effects to medications, tardive dyskinesias and rapid choreiform jerks, jachisthesias, these are called, weight gain, various side effects are also outlined in this review. Here's the patient from last week that had rat bite fever and this sepsis from Spirillum minus. All the details are outlined here, but they don't tell us what they did with the rat. The next patient has a urinary tract infection, received a catheter, and this is the color of his urine. Now this looks dramatic, but we actually had patients that had urine of this particular color. And the reasons for these colors are outlined in this metabolic pathways. Various bacteria can cause this. This patient had a Klebsiella urinary tract infection, and the microbiome is also involved here. You can read the details, but this is a dramatic discoloration of urine, and it's associated with infection rather than something that the patient ingested. Now, the patient of the week in the New England Journal also concerns me. This is a 16-year-old boy that showed up with jaundice. And when young people show up with jaundice, we generally think of hepatitis, A, B, C, D, E, or we think about some toxic reaction, or Wilson's disease, or some drug response, etc. But what's striking about this patient is if we look at this laboratory value is here, this patient has a white count of 700, and all the white cell line is depressed, and he only has 95,000 platelets. And I'm not aware of primary liver diseases that cause this kind of spectrum in the patient's blood count. And he's got right upper quadrant pain, and he feels appetite's reduced, and he has itching, and his bilirubin is almost 9, and that would explain that. And so this patient is evaluated. Now, since he had atypical lymphocytes in his peripheral smear, we would certainly hope that he has mononucleosis. However, his heterophile antibodies were negative, and all these various tests for hepatitis were also negative. So this probably isn't a primary liver disease. This is probably something that involves the liver in a secondary fashion. Here's an ultrasound examination of his liver, which supports that point of view. Various infections, Borrelia does not cause this kind of picture. I guess might think I would do a test for leptospirosis, though that wasn't discussed here. The discussant considers a differential diagnosis, but the discussant focuses on this blood count and reaches the conclusion that the child probably has childhood leukemia. And in childhood leukemia, it's primarily lymphocytic leukemia. And if we look at the peripheral smear, this is certainly an atypical lymphocyte. And here's a bone marrow specimen, and here are all these blasts in this peripheral smear, so this poor patient has leukemia. And an analysis is done, and here are a whole variety of genetic aberrations that are associated with acute leukemia. This patient did not have involvement of the Abelson tyrosine kinase or the breakpoint cluster region. These changes are more commonly seen in chronic myelogenous leukemia anyway, but they can occur in acute lymphocytic leukemia. Then the patient had flow cytometric studies done. The yellow and the red ones are the ones that shouldn't be there, and you can size up details on your own. Then there's this discussion, how is an acute leukemia of this nature to be treated in a patient that has ongoing severe liver disease when these drugs require the liver for detoxification, etc. And that's discussed here. So the physician begins this patient on prednisone and then carefully introduces daunorubicin and vincristine and asparaginase, and the patient seems to achieve a remission. Takes a long period of time, and this patient has a poor prognosis. The next topic is in the Lancet, and it involves two types of transcatheter aortic valves. And one of them is the standard valve, where the valve is introduced, placed across the old aortic valve, and then there's an expansion that's conducted through a balloon device that the operator has to do. And the second valve is a self-expanding valve. I couldn't figure out exactly how this works. I guess we'd have to go to the cath lab to find out for certain. But the Accurate Neo is the self-expanding valve, and the Sapiens 3 is the valve that's expanded by means of a balloon to be activated. So in this particular study, the self-expanding valve was compared to the Sapien 3 valve that's expanded manually, that's currently the state-of-the-art. And the hypothesis in the study is that the new valve is no worse than the old valve. That's the hypothesis. And so if we look at these patients, there are more than 370 patients in both the groups, and these are generally older patients that have aortic stenosis. And if we look at their valve annulus perimeter, and if we look at their aortic valve areas, these patients have pretty bad aortic stenosis. And they have various cardiovascular risk factors that we would expect in patients of this age, since they're above the age of 80. And then we look at the technical details of these two valve replacements, and I think actually just by looking at it, both of these valves look pretty good, although the procedural times are slightly different. The Sapiens valve took a little less time to put into place. Contrast volumina was also a little better. The anesthetic was no different. the pre-dilatation that's performed was more common in the self-expanding valve for technical reasons that I don't understand. But were these valves the same, this dot would presumably lie on this red dashed line. How this statistic is done, I have no idea. But it looks like the new valve couldn't be shown that the new valve is no worse than the old valve. So that's why these 2 points are in favor of the old valve, and these other variables here are no different. So basically, both valves were pretty good, but the study could not prove that the self-expanding valve is better than the valve that's expanded manually. Post-valve regurgitation, here the old valve looks pretty good, and maybe the mean gradient is a little better in the new valve than the old valve, okay? But a 10 millimeter of mercury gradient isn't bad anyway, and the orifice area was statistically significantly different, but whether or not that's clinically important, I don't know. So this study couldn't really show that the new valve is no worse than the old valve. Now this next study I thought was pretty interesting. It involves a technique with which I wasn't familiar, and this technique is called near-infrared spectroscopy. And this spectroscopic device is inserted in the coronary arteries by means of an ultrasound-guided probe, and this device, by methods that you can look up on your own, can determine how much soft lipid material is inside atherosclerotic plaques. And we would reason that soft lipid-filled atherosclerotic plaques are more likely to rupture than plaques that are fibrotic that don't have a lot of liquid material. And so in patients that underwent percutaneous intervention to have their culprit lesion fixed, they were evaluated at the same time with this near-infrared spectroscopic ultrasound-guided technique to look to see what the rest of their non-culprit plaques looked like. And these plaques were then measured in terms of their size and also their lipid content. Lipid-rich plaques, and the size of these plaques might also be important, and that was also evaluated. And then these patients were followed for 700 days to see how their plaques did. And if these lipid-filled plaques may put these patients at risk for a major adverse coronary event. And if we look at major adverse coronary events in non-culprit and indeterminate coronary location, these are the red guys here, and the culprit are previously stented maces. What we see is that the new non-culprit plaques did about as bad as the previously stented already culprit plaques. And if we look at these plaques in terms of their size, the small ones and the larger ones and the smaller ones didn't rupture as commonly as the larger ones because the scales here are different. But in both instances, these lipid-laden plaques had a tendency to rupture. Now, in last week's New England Journal, we looked at a study whether or not the cardiologist should just fix all the plaques. But with this technique, we might be able to select the plaques that particularly warrant fixing when the culprit lesion has been treated. Then the third paper in the Lancet is our nasal polyps. And these are debilitating problems in patients that have allergic chronic rhinitis, and that involves lots of patients. And these polyps you can identify by physical examination. And here's an example. This individual is not going to be moving much air through this side of his nose. And these are truly debilitating problems. And the treatment option here is dupilumab, which is an antibody that deals with both IL-4 and IL-13 cytokine receptors to block these so that they can't be activated, and in that way cytokine signaling through these two receptors that causes a lot of inflammation can be blocked. So the patients were randomized to the antibody or conventional care, and then they were followed. There were two different doses. The antibody is given every 2 weeks, and in some of these patients it was given subsequently for another 28 weeks, every 4 weeks, and we can look at the results and you can look at the details. But here are the patients that were treated with the antibody for 24 weeks, and then the antibody was discontinued and they relapsed. But if the antibody was continued for 52 weeks, then the patients did better while they were being treated with the antibody. So this antibody might offer these poor patients that otherwise require a lot of steroids or have to be operated upon better treatment options. So here are the patients that got antibody, and here are the patients that got conventional treatment in terms of whether or not they required additional steroids or whether or not they had to be operated on. And these patients here in the blue were spared these interventions. So this might offer these patients an additional option. Then the reviews in the Lancet involve drug abuse. And the first review involves global stimulants. And I don't know much about this, but one of them obviously has to be cocaine, and the other one has to be amphetamines. And then there are various other concoctions that are tailored in certain laboratories that are also function as stimulants. This is a problem. So here's cocaine, and the cocaine abusers, no wonder the Bolivians and the Colombians do well. Look at the United States and Alaska. Canada is also up there. And in Europe, we don't have too much to be proud of. Here are the Australians. They seem to like this stuff also. And the gray countries have presumably didn't report any data. But cocaine is a problem. Then here are amphetamines. And then here's expression in terms of 100,000 population. Cocaine and amphetamines looks about the same as the last graph, although, so this is a major problem, cocaine and amphetamines. Here's Australasia in terms of amphetamines, seem to be fairly popular, but the illicit use of this material is astounding. And I think that's very depressing, and you can inspect the details here on your own. And whether or not the patients concomitantly have hepatitis C or HIV or other medical problems and sexually transmitted disease, and you might imagine that all this might be the case, and criminalization, compulsory detention, and all of these kinds of problems. So those are the key messages. So this is a major worldwide health problem, and no one knows exactly how to deal with it. Then the next review is on what we might face in the future. If that wasn't enough, new psychoactive substances. Do we need any more of this? But apparently it's coming whether we like it or not. And I know nothing about this, but NMDA and various compounds that are being developed, and cannabinoids and euphoria producing compounds. This is all terrible. Here's a different example of problems in Ireland, Russia, New York, etc., North America. Awful. So if you're into this, incidentally, here's use in adult populations. US again leads the pack. Germany doesn't look very good, and Switzerland and Austria aren't very good either. So this is also a problem. And here's Spain. So these things, and young people, presumably people that are under 18 years of age, where this material seems to be these kinds of new compounds that we're going to face. Look at Poland here. Don't even want to think about it. So if you're if you deal with this thing, these two reviews might help you in considering what's going to be facing us in the future. Now, the final topic, and this is very sad, concerns tuberculosis of the spinal column. And tuberculosis of the spinal column before 1950 was pretty common, and the condition was first described by Sir Percival Pott. So this is Pott's disease, and it results in these kinds of lesions that don't really destroy the disc, but they do destroy the bone, so that the bones collapse and the spinal cord can be incapacitated. So these people develop paralysis and have the risk of becoming paralyzed. And in this sad story, this 4-year-old child living in Mozambique has a 3-month history of night fevers, night sweats, non-productive cough, weight loss, and it's known that his grandmother has tuberculosis. So all this was clearly avoidable, and the diagnosis is established by conventional techniques, but after he's already paralyzed. So here's his lesion, here's his chest x-ray, he's got pulmonary tuberculosis, and here's Pott's disease. So all of this could have been avoided. That's very sad. Thank you for your attention. And if you'd like to hear all this in German, you can stick around for 18 minutes and we'll discuss it further. Thank you very much.
Vielen Dank, Herr Löw.
Bitte, bitte. Ihr braucht nicht warten, wirklich.